Hello, I'm Carrie Cooley, Consulting Coordinator and Lead Nurse Planner for Weatherbee Resources. The title of today's presentation is Responding to Payment-Related Scrutiny. Oftentimes, hospices are not aware that they are under any sort of payment scrutiny until they get a letter in the mail from their Medicare Administrative Contractor or from another governmental payment agency. Initially, when you see the letter, it often is enough to make you cry. So the purpose of today's presentation is to prepare everyone on how to react, how to respond, and how to survive payment-related scrutiny for Medicare and Medicaid patients. So you found out that you're under some sort of medical review. What does this mean? Record reviews are conducted to ensure appropriate payment for services that are provided to patients. Because most of these patients are Medicare recipients, these audits or medical review are performed by Medicare Administrative Contractors, or MACs. In past years, Medicare Administrative Contractors were referred to as fiscal intermediaries, or RFFIs. However, the new abbreviation for MAC went into effect several years ago. Most medical review is initiated through a process called ADR, or Additional Development Request. In other words, the MAC is stating to the hospice that additional documentation is needed to validate the hospice's ability to receive payment for the services delivered. CMS mandates these probe edits through the ADR process, and ultimately, if correction is not seen, through Progressive Corrective Action Plans, or PCAs. Medicare Administrative Contractors carry out progressive corrective actions based on the provider and other data that's gleaned through the medical review process. So, before you is a map for Medicare Administrative Contractors who manage home health and hospice jurisdictions. At the present time, there are 4, which is Palmetto Government Benefits Administrator, or Palmetto GBA, NHIC, which stands for National Heritage Insurance Corporation, Cigna, also known as CGS, and last, National Government Services, often abbreviated as NGS. So based on the location of the hospice provider, their MAC is determined. So Medicare Administrative Contractors have many responsibilities. Some of them are listed here. The primary thing that they do is pay hospice claims to providers. So in other words, the hospice bills the MAC for care that was provided, and the MAC in turn reimburses the hospice. But Medicare Administrative Contractors also have responsibilities around education, prepayment and postpayment review of claims, which is also called probe edits. They issue the ADRs. They review medical records, both at the ADR level and the Level 1 appeal, which is called a redetermination. They also pay claims and issue denials based on their medical review. They calculate the charge denial rate, which we'll talk about more in just a few minutes. And they initiate the Progressive Corrective Action Plan when a provider's charge denial rate exceeds 10 to 15%. So let's begin by talking about probe edits. So there are 3 types of probe edits. And remember, this is the initial medical review scrutiny that hospices often experience. So the 3 types are service-specific, provider-specific, and beneficiary-specific. So for service-specific, this is based on the kind of provider that you are. So we're going to talk specifically today about hospice providers. Next is provider-specific. What this means is that the probe edit is specifically targeted to the provider of hospice care. So it's a specific hospice involved. And then beneficiary-specific is when a particular patient is involved and a probe edit is generated because of who the beneficiary is and their likely past payment history. So let's talk more about the service-specific edit. The way that these edits come about is essentially through what's called data mining. So as you know, hospices submit many types of data throughout the year. And what the MACs do is compare the hospice's data to their peers, both regionally and nationally. When a hospice, when an industry stands out, it can often initiate a service-specific edit. So for example, we might see a random sampling of 100 claims from the universe of providers who fit the edit criteria. So what that means is, if they see a particular issue, it could be around a particular diagnosis, the MACs have the ability to begin a probe edit just based on those criteria. Each Medicare Administrative Contractor does publish what it is focusing on from an edit perspective, normally on their website. And also, they review the findings quarterly of these service-specific edits to determine if an edit needs to continue or if they've gained sufficient information regarding the data inconsistencies that they may have seen. Next is the provider-specific edit. So this is regarding, again, a specific hospice provider. So what they do is they begin with a small number of claims. Those are selected for review. And some of the reasons include that the hospice's data may be atypical in light of their peers. Also, hospices who are newly Medicare certified, or if there was a change in ownership. And thirdly, if the hospice's billing has increased significantly over the prior years. So those three things are specific examples of what might lend a provider to probe edit. And lastly is a Medicare beneficiary specific audit. And what this is when a Medicare beneficiary's eligibility is questioned, then they will be under probe edit. So for example, let's say that Mr. Smith was on ABC Hospice back in 2012. As part of ABC Hospice's medical review, let's say that Mr. Smith's medical record was pulled and payment was ultimately denied because he did not meet the medical clinical eligibility for hospice. If Mr. Smith subsequently transfers to, let's say, G Hospice, then there's a high likelihood that Mr. Smith's clinical record will be requested because he received a previous denial, even though it was under a separate hospice provider. One of the most important things to ensure when a hospice comes under payment-related scrutiny is to ensure that the process for handling these kinds of audits is clearly defined. So let's talk about how that happens. So as we said, the MAC generally sends an ADR to the provider requesting supporting documentation for a specific claim and dates of service. Most often, this is in a 30-day time frame, or they may request a smaller amount of data if the patient was discharged or died during the month of service that's being reviewed. You can also find the ADR in the Fiscal Intermediary Standard System, or FIS system. Once the hospice submits the data timely, the MAC reviews the documents and makes payment determination. In other words, they decide if the hospice has sufficient documentation to support eligibility or if they do not. And this takes into account both the technical and clinical requirements for hospice. And then an error rate is calculated after all of the requested records are reviewed. So let's talk more about the charge denial rate, or an error rate. So the CDR is always expressed as a percentage. And the way that it's calculated is they determine the total amount of dollars denied by dividing the total charges of all claims reviewed and multiplying that number times 100. Again, this is not based on the number of claims that are denied and or paid. It's based on the dollar amount denied as opposed to the the total dollar amount denied in comparison to the total dollar amount that was billed. So what does this mean for a provider? Obviously, there's a financial impact. So let's look at an example. During a probe edit, a provider submits records for claims amounting to $10,000. If they denied $2,500 worth of claims, then the charge denial rate would be 25%. And the way that they get that number again is dividing $10,000, which is the total amount billed, by $2,500, and then multiplying that number times 100. If the charge denial rate is greater than 10 to 15% on the initial probe, an additional probe will usually be completed 60 days later. During the second probe, if the charge denial rate remains above an acceptable level, then the provider will enter what we call targeted medical review, or TMR. TMR means that if the hospice remains under review for at least one more 3-month quarter, and they will remain under scrutiny for an additional quarter, and they will stay there until the charge denial rate reaches an acceptable level for an entire quarter. If the provider still continues to have a high charge denial rate, then the Medicare Administrative Contractor may request a written corrective action plan. In other words, your Medicare Administrative Contractor expects to see improvement in your documentation and compliance. Otherwise, they continue their edit. So how can an organization respond to payment-related scrutiny? So really 3 words: get organized, get educated, and get started. ADRs affect an entire organization, and you have to ensure that you handle them very judiciously because they can put the hospice in danger of serious and sometimes insurmountable financial difficulties. Please note that it can take a year or more to go through the appeals process, so it's imperative to approach this process in a systematic and well-organized manner. So let's talk about getting organized. The first thing that you want to do is appoint an ADR coordinator. This is the person that will handle the receipt, the processing, the response, and the overall management of any ADRs received. Hospices should make sure that they review their policies and procedures, any documentation templates that may exist, staff practices, particularly around clinical record documentation, internal communication and processes, job descriptions, and staff responsibilities. We want to make sure that the entire organization supports the ADR coordinator. It's a very difficult job, and it's so important that this person have the resources that they need to complete the task at hand. The next thing that you want to do as an organization is develop a system for checking the FIS system regularly. Often, ADRs will be notified. You'll be notified of an ADR there first. And next, develop an ADR tracking tool. You want to track the dates that the ADR was received, who initiated the ADR, the date that all of the documentation is due for submission. Also, please make sure that when you do send the documentation in to the Medicare Administrative Contractor, that you allow yourself to have a tracking number and also have a method to show receipt by the MAC. You also want to include the outcome of the ADR and if you decide to appeal or not, and why. So you want to track the initial charge denial rate for each batch of ADRs received, and you want to continue tracking them across all levels of appeal. And you also want to track and trend all of your appeal outcomes, both favorable and unfavorable. Lastly, you want to make sure that you copy and submit all favorable ALJ decisions if the patient involved has received serial ADRs and or serial ADR denials. Also, it's important to get educated on these things. When submitting your clinical record for review, I strongly recommend writing a summary letter to make the best case possible for claim payment. This should be written by someone in your organization who has reviewed the clinical record and is able to succinctly state the patient's eligibility in the letter. The letter should be the first page of the documentation that you send in for review. You want to also get educated on how to navigate the appeals process. In the next slide, we'll talk about the appeals process, but it's important to understand not only who you're appealing to, but the timing requirement as well. And most importantly, you really want to get educated on how to use the ADR process to improve your clinical record documentation and patient assessment for eligibility within your organization. So let's talk a little bit more about the ADR appeal process. So the levels of appeal, so you have the initial ADR, and then if that is denied, you move to the first level of appeal, which is called redetermination. Your Medicare Administrative Contractor is the one who will complete the redetermination, and it has to be done 120 days from the receipt of the demand letter. The level 2 level of appeal is the reconsideration level. This is conducted by an independent quality insight organization, so it's not your MAC. This is a completely separate organization that will be reviewing the claim. And it's done 180 days from the receipt of the redetermination decision. Level 3 is appeal to the administrative law judge, which occurs 60 days from the receipt of the reconsideration decision. Generally speaking, the ALJ level is the highest level of appeal that hospices do. However, there is a level 4, which is an appeal to the Medicare Appeals Council, which also occurs 60 days from the receipt of the ALJ decision, or Federal District Court, which also has a 60-day timeline. Generally speaking, the 4th and 5th levels of appeal are reserved when the hospice believes that the Medicare Administrative Contractor, the QIO, or the ALJ has conducted itself inappropriately and it's not adhering to the legal requirement for hospice. So the takeaway from this presentation is that documentation is critical. If it's not in the record, then it didn't happen. Unfortunately, Medicare reviewers and those above Medicare reviewers never get the opportunity to see the patient. So it's important that every piece of documentation submitted for review significantly contributes to your request to get paid. In other words, everything that you do should be captured in paper, particularly around clinical eligibility, technical eligibility, and medical necessity for hospice. It's important to document not only the patient's eligibility, but that the appropriateness of services was, that the services provided were appropriate, and if the patient experienced a higher level of care during the dates of service reviewed, such as the general inpatient level of care or continuous care, that the documentation captures the medical necessity of the higher level of care. Physicians are the only ones who can certify patients as terminally ill. So strong physician documentation regarding the patient's prognosis and other clinical eligibility factors can make the difference in getting a claim paid or in getting a claim denied. Technical denials can be avoided if you have appropriate processes in place. So make sure that all of your forms, signatures, dates, and things associated with timelines are completed appropriately. And last but not least, keep in mind that the LCDs, or local coverage determinations, matter a lot. So please make sure that your documentation focuses on the LCDs to substantiate initial and ongoing clinical eligibility. I hope that you've enjoyed this presentation. Please find on this slide contact information. However, I do request that you contact Peter first. You'll see his email and his phone number, and he will in turn forward your question to me. It's been a pleasure to be on the call with you. Thank you so much.